Hello, welcome to our next lecture with the Geriatric Health Lecture Series. My name is Barbara Cochran. I'm the director of the DeTourney Center for Healthy Aging here in the School of Nursing. Today I'm representing the Northwest Geriatric Education Center, which is sponsoring this series of lectures for people around the region, and so welcome. It's my pleasure today to introduce Heather Rogers. She's a clinical assistant professor in the Division of Dermatology at the University of Washington School of Medicine, dermatologic surgeon at Madison Skin and Laser Center. Dr. Rogers is a board-certified dermatologist with fellowship training in, I'm not going to pronounce this right, Mohs
micrographic surgery.
Mohs micrographic surgery, dermatologic surgery, photodynamic therapy, cosmetic dermatology, and laser surgery, all of which are topics I know nothing about, so this is going to be great. She specializes in the prevention and treatment of sun damage and skin cancer. She has lectured internationally as well as published numerous articles and book chapters in the field of dermatology. So we all have a lot to learn from her today, and welcome.
Thank you. Okay, I'm going to sit down and hopefully we'll keep everyone interested. Yes, that's okay.
I wanted to say verbally, I'm sorry, folks, that we're trying a new thing today, and that is to turn off the chat so it's not being picked up on the video recording that we're making. So if you have questions for the lecture, please email them to me, barbc@uw.edu. Again, that's barbc@uw.edu. If you have technical questions, please call John Balzerini, and you have his phone number. So just to let you know that the chat is disabled on our end. Thank you.
So today we're going to talk about sort of the most common skin lesions seen in the aging adult. And I'm going to start with the more worrisome lesions, and then we're going to sort of spend the last third talking about benign lesions, which is really important for you to know about because there's a lot of resources that get spent, particularly in less populous areas, getting people to be seen by specialists for lesions that end up being benign. So my goal is to we're going to look at probably 300 photos today, and the goal is just to get you guys up to speed on what's bad, what's not bad, and when you don't know what to do about it. And let's hope we will progress. And we're progressing. Okay, so the three different sort of groups I'm going to talk about are premalignant lesions, the most common of which is something called an actinic keratosis. Pretty much anyone over the age of 65 will have at least one AK. Malignant lesions, which are basal cell or squamous cell carcinomas, and the other sort of group of skin cancer are melanomas. Melanomas are a very different bird than the basal cells and the squamous cell carcinomas. And then hopefully we'll have time to talk about all of these different benign lesions, Nevi or moles, acrocordons, which is a fancy name for skin tags, lipomas, cysts, cherryangiomas, sebaceous hyperplasia, seborrheic keratoses, and venous lakes. All things that you start getting about the age of 30, 35, and you just keep getting more of as you age. So starting with skin cancer. Skin cancer is a big deal, and the reason why it's a big deal is because it's incredibly common. If you reach the age of 65, 50% of you will develop a skin cancer. So it's something that in your guys' patient population you're going to see, and it's something that's important for you to know something about. There's over 3.5 million cases diagnosed every year in the U.S. alone, and this incidence actually just keeps increasing because people are living longer, they're outside more, they're more active, and so skin cancers are continuing to be developed. So what causes skin cancer? There's really sort of two different factors. One is your UV exposure. So ultraviolet radiation comes in two forms, UVA and UVB. Both are associated with causing skin cancer. SPF, which is everywhere in sunscreen, actually only talks about protection from UVB. So it doesn't address UVA at all, and that's something that's just been changed by the FDA this year, is they're now going to make sunscreens talk about having broad spectrum protection so that you get protection both from UVA as well as UVB. And then the second thing that's really important is hereditary. If your mom had a skin cancer, your dad had a skin cancer, that increases your risk of having a skin cancer. If you have a family history of melanoma, that increases your risk of developing melanoma. So this is just a great study that was done out of Case Western, and these are two women who are twins, and it was a twin study looking at sort of the risk of developing skin cancer and the effect of sun exposure on aging. And these women are the same age, but the woman on the left lives in Florida, and the woman on the right lives in Wisconsin. And you can see that chronic sun exposure really ages the skin, and in association with the aging of the skin also increases your risk of developing skin cancer. So starting off with premalignant lesions, the most common lesion is an actinic keratosis. There's over pretty much 95% of people over the age of 80 have at least one. And why they're important is that they can turn into skin cancer. Not commonly. It's not like every pre-skin cancer turns into skin cancer, but somewhere between 2 and 10% of actinic keratoses become skin cancers. And they develop in areas of chronic sun exposure, and where you see them is on your elderly ladies and gentlemen's backs of their hands, those little rough spots. And they're almost easier to feel than to see. And this is a gentleman's face, and you can just see he's covered. He probably has 15 of these little rough scaly areas. Each one of these are a pre-skin cancer or an actinic keratosis, and about 10% of them are going to turn into skin cancer over time. This is a pigmented actinic keratosis on a woman's cheek, and it's brown and it's pink and it's red and it's scaly, and it's just a pre-skin cancer, but left alone it's large enough where the risk of it developing into skin cancer is pretty high. This is on the back of a hand, and sometimes the AKs can get raised or rough or a little bit crusty. And when they get particularly thick, that's when it's harder to tell, is this just a pre-skin cancer or is this an actual skin cancer? Here's one on the arm. The actinic keratoses on the arms and on the legs can get very, very thick and warty and almost look like a wart or a scab. And it's not either of those things. It's just a pre-skin cancer. And what it is the cancer, the skin cells are just dividing a little bit more quickly than they need to be, and that's the reason why it gets so rough and scaly. This is a gentleman who is immunocompromised, and people who are immunocompromised make a lot more skin cancer and a lot more pre-skin cancers, such as organ transplant patients, people who've had bone marrow transplants, people who are on immunosuppressive medicines like prednisone, Cellcept. Those individuals have an increased risk of developing skin cancer. Organ transplant patients actually have 100 times greater risk of developing squamous cell carcinoma. So these individuals can just become peppered with these little crusty areas that then have a higher risk of turning into skin cancer. So what do you do with actinic keratoses? For the most part, you watch them, and if they're crusty or irritating or growing, as a dermatologist, I treat them with liquid nitrogen. Other things that you can use to treat them are their prescription strength creams. 5-fluorouracil is a chemotherapy agent that is used intravenously for a number of different cancers, but is used topically in the form of Efudex or Carac. And those are creams that you just have the person use on the backs of their hands or on their face for a relatively short period of time, 2 to 4 weeks. It makes them incredibly red and irritated and miserable, but it clears them up and makes them look actually about 10 years younger after they've used it. Imiquimod is a very expensive, it's about $750 a month, and it was FDA approved for the use for genital warts. And what it does is it activates your own immune system to notice the lesion and kill the lesion. And it also now has received FDA approval for the treatment of pre-skin cancers or actinic keratoses. Diclofenac, which is an NSAID, was most recently FDA approved for the treatment of actinic keratoses. And my honest opinion is it doesn't work very well. You have to use it twice a day for 90 days, and there's about a 50% improvement. So it's not something that I use very regularly. Something that's actually very, very popular outside the U.S. and is becoming more popular in the U.S. is photodynamic therapy. And that's a treatment that's actually used for a lot of different things. It's used for lung cancer, it's used for bladder cancer, but it also can be used for skin cancers of the skin. And we're going to talk about that a little bit more. What PDT is, or photodynamic therapy, is you apply a chemical to the skin, you allow it to incubate for an hour, and what's wonderful about PDT is that chemical is preferentially taken up by the pre-skin cancers. It gets converted to a chemical called protoporphyrin 9, which is really sensitive to light, and then you put them underneath the light, and it preferentially kills off the cancer cells and the precancer cells. I do a lot of PDT. I think I probably do the most PDT in Washington, and patients come from all over to get this treatment because it's so much more humane than getting liquid nitrogen all over your face or getting the Kerac all over your face. And it's covered by Medicare. Medicare actually thinks it's a great treatment. So this is a gentleman who is covered with actinic keratoses after 2 treatments of PDT. And you can just see the texture of his skin is so much better. And why I really like photodynamic therapy, or why it's important to treat the actinic keratoses, is in my mind it separates the men from the boys. Meaning you get rid of that background noise and you can actually see the skin cancers or the things that are getting worse after you get around all of that sun damage removed. So that's AKs, or actinic keratoses. We're now going to talk about the 3 most common types of skin cancer, which are basal cell, squamous cell, and melanoma. Basal cells are the most common skin cancer. There's about almost 3 million cases diagnosed each year. If you have to have a cancer, this is the kind of cancer you want to have. It's slow growing, it doesn't spread, or incredibly rarely spreads, and it's usually very easily cured. Exciting news on basal cell carcinoma is actually yesterday the FDA approved an oral chemotherapy agent for the treatment of basal cells for people who are poor treatment, poor surgical candidates. And I think that we're going to be continuing to make progress on non-surgical treatments for skin cancer, which is wonderful. So risk factors for basal cells, primarily it's how much sun you've gotten and your family history. Your family history both for the history of developing skin cancer, but also your family history, meaning what do your people look like? Are you fair? Do you have light eyes? Do you have light hair? Because that's going to put you at increased risk of developing skin cancer. Exposure to radiation, arsenic, non-healing wounds, immunosuppression, those increase your risk for basal cells, but they greatly increase your risk for squamous cell. So your risk for a basal cell might go up 5 times if you have immunosuppression, while it goes up 100 times if you have immunosuppression for a squamous cell. There are lots of different types of basal cells, and I'm not expecting anyone to remember all of these types besides me because it's my job. But why I have them all up there is because it's important for you to know that a basal cell can present a lot of different ways, and that's the reason why there's so many different types. Is there's bumps that are basal cells, there's itchy patches that are basal cells, there's scars that are basal cells. And so whenever you see a lesion on one of your patients and they don't have a good story for you about how long it's been there or why it's there, you need to be suspicious that it's a skin cancer, because skin cancers can present 100 different ways. So we're going to go through these different types of skin cancers and just look at the pictures and sort of get a feel for the variation. And can I turn off the light up front, or is that, can I not do that?
I don't think it will help that much.
It might help a little bit. That might help a little bit. Just so you guys can sort of see some of the texture. So this is a classic nodular basal cell. And as you can see, there is this pearly pink papule on the side of the nose. It has a central indentation, and probably if he rubbed it or scratched it, it would bleed really easily. Skin cancers don't behave like normal skin. They're much more friable. They're much more likely to bleed. So if somebody shaves their face and they always nick themselves in the same spot, you have to think, okay, why are they bleeding there? Is it because they have a skin cancer? Another little pearly pigmented papule under the eye of a gentleman. On the nose, it can look like a mole, it can look like a little cyst, but these raised, shiny papules with little broken blood vessels in them are classic for skin cancers. This is on the arm of a gentleman, and it's near a scar, and it's just a nodular basal cell. Elderly woman with a little, she actually has 2 here. She has one underneath her eye and one on her nose, these shiny pink papules. Not a very unimpressive little crusty spot in front of this gentleman's ear that just never healed, and it was itchy. He would scratch it, it would bleed, and you do a biopsy and it comes back as a skin cancer. This is a sort of warty, raised papule on his cheek. He thought it was a wart, and it's a skin cancer. So basal cells really like to develop in the nasolabial fold, or in this little groove here, and I'm going to show you about 6 pictures in a row of just little basal cells hidden in the little corners here, where they're subtle, and then this is one's a little less subtle. It's a lot bigger. They can be deep and almost look like a cyst underneath the skin, and it's a basal cell. And then they sometimes develop in bad places. Basal cells are the most common skin cancer around the eye, and this is a big basal cell all in the medial canthus of this gentleman's eye. This is a small basal cell, but it's in a really bad place. You can see there's loss of eyelashes along the lower lid margin, and there's that pearly area with the little broken blood vessels. That's a basal cell. So whenever somebody has an area on their eyelid where they have a loss of eyelashes, a loss of eyelashes is usually suggestive of something growing there that shouldn't be there. Next type, ulcerative basal cell. So this is the wounds that you wonder if they're scratching, or if they have any leg wound that doesn't heal, you have to worry about, is that a skin cancer? Skin cancers are actually more prone to develop in non-healing ulcers. So somebody could have a stasis ulcer or a pressure ulcer for several years, and it can turn into a skin cancer. So whenever I get a patient referred to me who has a non-healing wound on their leg, despite getting excellent wound care by the wound care nurse, I always do biopsies. And frequently it comes back as a skin cancer, and they can be quite large on the lower extremity. This is a gentleman who just had this crest, and he thought it was from bumping his shin against the table, and it's just a big basal cell. Superficial basal cells are incredibly innocuous. They don't look like anything. So you can see that's just not impressive. It's a little pink scaly plaque. It looks like a patch of eczema or a little patch of dry skin. And they frequently grow out more than they grow down. So they aren't hard to treat because they're superficial, but they frequently are ignored until they get quite large. So a little pearly papule on the woman's chest that ends up being a little superficial basal cell. Little pink area on the arm that just doesn't ever go away. Pigmented basal cells are just ones that are concerning for melanoma. So you can have a dark new spot on somebody's skin, and it can be a basal cell, it can be a melanoma, or it can be something else. And we'll talk about the something else's afterwards. But this is not a melanoma, although it looks like a melanoma, and if I saw it, I would be worried about melanoma. This is actually a basal cell, which is a much better diagnosis for the patient. Individuals who have darker skin types, so people of Asian descent, of African American descent, of even really just Greek darker skin tones, tones that tan easier, those individuals can make very, very dark lesions that are just pigmented basal cells. Sometimes they can be, just big brown pink patches that look like a dry spot or a healing crust, and it's actually a big superficial basal cell. Morphiiform basal cells are the ones that are frequently missed. Morphiiform is just a fancy word for scar-like. They can look like anything. This is a patient of mine from the VA who just had this big sort of white patch on his chin. It didn't really look like anything, and that whole area that I've circled in purple is actually a morphiiform basal cell. This is a big morphiiform basal cell behind a gentleman's ear, and it's not bleeding, it's not crusting, it's just a little bit of texture change. It looks like a scar, and it ended up being a large skin cancer. Same thing here. You see there's sort of a pink and white change to the skin, and these are the individuals who are like, did you have a burn or did you injure yourself? And they say no, and yet they still have this patch that looks like a scar. That's when the alarm goes off for me. Okay, I got to do a biopsy and see what else this could be. This was on somebody's elbow, a good place where you could scratch yourself, and ended up being, a 4-centimeter skin cancer on their arm. This is not a very good picture, but it's a young woman who has this big yellow patch between her nose and her cheek, and it was all a big morphiiform basal cell. Cystic basal cells are very rare, but when you see a little cystic space like this, and you pop it and it grows back, and you pop it again and it grows back, do a biopsy on it, because why it's coming back? Maybe because it's not a cyst, but because it's a basal cell. Same thing, this is just a little pocket of fluid when you pop this, but it comes right back, and that's concerning that it's a basal cell. So just sort of background information for you guys about basal cells is that they grow relatively slowly. They double in size annually. So if somebody has a basal cell for 5 years, it's not going to be the end of the world. They aren't emergent. They aren't like a melanoma where you really need to treat them sooner than later. Primarily, they're locally destructive. So why I treat basal cells is because it's much easier to give somebody a small scar on their nose than a big scar on their nose. And they're going to continue to grow, and they're going to continue to eat down into the cartilage, into the muscle. I actually had one patient who died of a basal cell that ate through his shoulder and actually into his lung. But usually people don't die of basal cells unless they're in denial of the fact that they need treatment, and they allow it to go untreated for years, decades. And these are some "Are you awake?" pictures of scary basal cells that have, just been left alone for too long. And this is a gentleman who presented to the ER because he was incredibly fatigued and he was anemic from chronic bleeding from his basal cell that really had eaten away the majority of his face. And this is an elderly woman who just refused to have it be treated, and she knew it was a basal cell, and her doctors had tried very hard. And actually, my husband's an ear, nose, and throat doctor, and this patient presented to him, and this is all a basal cell that just ate away her entire lower lip. And then this is a woman who presented to me, sweetest lady in the world, who lived alone for 30 years and just allowed this basal cell to continue to grow and grow and grow, and it, invaded down into her eyelid, into her scalp. So take-home points for you guys about basal cells. Pretty much any persistent non-healing sore, you want to think, okay, skin cancer. A red scaly patch that doesn't go away with appropriate moisturizer. Anything that's pink rolled border that's sort of shiny like all those pictures were. And then a scar-like area with no good history of why they would have a scar there. Those are things that should make you think, okay, we have to reevaluate this. Squamous cell carcinomas are the second most common type of skin cancer, and in my mind, I group those like basal cells. So there's a term in dermatology called non-melanotic skin cancers and melanomas. Non-melanotic skin cancers are primarily basal cells and squamous cells. They're less aggressive. They're more easily to treat. They're a little bit more easy to treat. Out of the two, squamous cells are more aggressive than basal cells. Basal cells are the most benign, and melanomas are the worst, and the squamous is sort of in between. Squamous cell carcinoma used to be primarily a disease of men who worked outside. It's really associated with long-term chronic sun exposure. And when actinic keratoses turn into skin cancer, they usually turn into squamous cell carcinomas. Similar risk factors for squamous cells as there are for basal cells. Like we talked about before, immunosuppression, radiation, chronic wounds are actually a much higher risk for squamous cells than they are for basal cells. The other thing that is interesting or concerning about squamous cells is that they're associated with the human papillomavirus. So when people have a squamous cell, the risk of it recurring is actually higher, and part of that reason we think is because there is a wart component to it or a viral component to it. So even when you treat the skin cancer, the wart or the virus is still on the skin, and it can create another skin cancer. So people do get squamous cell carcinomas, for example, of their genitalia, and that's related to the human papillomavirus. People get squamous cells underneath their nails, and often the squamous cells on their fingers and nails is related to the human papillomavirus. So these can look a lot like basal cells, and they can look a lot like pre-skin cancers or actinic keratoses. They're just crusted, raised papules. Squamous cells frequently are tender, that if there's a little bump that's not that impressive, but the patient's like, it's tender when I rub it or when I bump it or when I scratch it, that's a pretty good prognostic factor that it's a squamous cell. They can grow these things called cutaneous horns, which are like these little unicorn growths that, in my mind, are usually a good thing. If things are growing out, it means they're probably not growing down as quickly, and so I like things to grow up and out versus down. Sometimes it's wonderful, as you guys know, elderly individuals are incredibly tolerant, and they can come in with these very, very long horns that they've been growing for 3 years, which I would not have tolerated. They can look like little infections or little inflamed cysts that just stay. What I always tell my patients is, if you have a bump or a lump, that's completely normal unless it's there for more than a couple months. If the bump or the lump stays for longer than 2 months, then we have to evaluate. It's not just a typical blemish. There's something else going on, particularly in individuals in the over 65 age group. Like, they just shouldn't have blemishes for that long. This is, was an area where she thought she had just scratched and it didn't heal. Anything that doesn't heal over a couple months, then you got to think, okay, there's something else going on. And on the lower leg, just a chronic wound that didn't heal. This is a gentleman who had 2, one on his shoulder, one on his elbow. They can be pink and black or brown or crusty, and as they grow out, sometimes they hold on to the dead skin cells, and they can look very warty, like this one does. Lips are a very common place where people develop squamous cells. The human papillomavirus really likes mucosa. It likes wet environments, and so around the lips, you can also get skin cancers. And frequently when people have a non-healing fissure or sore on their mouth, particularly on the outside of the mouth, that's something where I will do a biopsy, and the incidence that it is a skin cancer is actually remarkably high. They can just be crusted areas in the area of a lot of sun on the scalp. This was, again, a non-healing wound from a burn on an elderly lady's back of her arm, and it ended up just being one big squamous cell after not healing for about 3 years. This is a heart transplant individual who has a big squamous cell on the tip of his nose. As I said before, transplant patients have a great increased risk of developing skin cancer, and the more immunosuppressive medicines they are, the greater their risk is of developing skin cancer. This is a dystrophic nail or a deformed nail. And why it's deformed is because it has a wart virus there that then turned into a skin cancer. There are subtypes of skin cancer of squamous cell, and one that gets thrown around there that's sometimes confusing to people who aren't in the dermatology field is this term called Keratoacanthoma, or Ka. It's just a subtype of a squamous cell. There's nothing really that fancy about it. They can be scary for patients because they grow really quickly. So like over a 6-week period, they'll get this big volcanic looking thing on their face. And again, it's usually a good thing because it's growing up instead of down. And they are usually actually one of the less aggressive subtypes of squamous cells. But you can see there are these big bumps with a central core, and they all look the same no matter where they develop. Big bump with a central core. And they can be on the shoulder, on the eye, and they just grow very quickly, so they're scary. That's in a horrible location, but again, they're growing up instead of down, so they're usually easier to treat. A second subtype of squamous cells is something called Bowen's disease, which is just a guy's last name for a superficial squamous cell or a squamous cell in situ. And these look almost identical to a superficial basal cell. It's just one is made from keratinocytes and one's made from basaloid cells. But it's an early stage of a squamous cell. It's very superficial. It's only in the top layer of the skin. And they look like itchy red patches, much like the superficial basal cell looked like. Again, these are associated with the human papilloma virus, so they're very common on the hands, on the genitalia, in areas where the virus is more likely to grow. And then, as maybe you guys have seen or heard, there's you can get papillomatosis of the genitalia, and it's these little scattered red papules, and that can very quickly turn into superficial squamous cell. And that's one of the reasons why we treat it. So squamous cell carcinomas, if you had to have a skin cancer, you want a basal cell. Squamous cells are your second first choice because they can grow pretty quickly, and they do kill people every year. Somewhere between 0.5 and 5% of squamous cells metastasize. The ones that do metastasize are big, ugly skin cancers that have been left alone for a long time. It's not the small little squamous cell on the back of somebody's ear or on their hand. They're ones that are usually larger than 2.5 centimeters in size. They're ulcerated, and they've been left alone for a long time. These are examples of squamous cells that you would worry about metastasize. You would feel them for lymph nodes. You would even consider doing imaging studies because the lesion is big and it's been there for a long time. Things on the ear, things on the mouth, things in scars all have an increased risk of metastasizing. So big lip lesions. And unfortunately, once a squamous cell metastasizes, the cure rate is really, really low. I mean, the mortality is about 50% at 5 years once the metastases happen. So you really want to catch them early. And this is an organ transplant patient, who has 3 spots that are all concerning for metastases. And then this is an organ transplant patient who just grew this horrible squamous cell like overnight, and those are swollen lymph nodes on the back of his neck. So this one has already metastasized. And so when they're immunocompromised like that, they can just go quickly in weeks. It can spread. So warning signs for squamous cells are pretty similar to basal cells: persistent non-healing sore, a bleeding scaly patch, any sort of wart-like growth with those little horns. If it's tender to the touch, you want to be suspicious of it. And then if it's that big sort of papule with the center crater, it's probably a keratoacanthoma. So what do you do if you have a patient who you think has a skin cancer? Well, the most important thing to make sure that the patient gets the right treatment is to know what you're treating. So when it's humanly possible, you want to get a biopsy. And the biopsy is going to tell you what type of skin cancer it is, how deep it is, the subtype, which is important because some types of skin cancers you can treat any way you want. Other ones are really aggressive and you really need to cut them out. And I have a preference for my slides to be read by dermatopathologists because that's what they do all day. And DermPath Northwest is wonderful in the community. And here at the UW, we have great dermatopathologists. So treatment is actually really easy. You know, even though I'm a surgeon and I like to cut things out, I really like the punishment to fit the crime. So if you have a superficial skin cancer, I'm not going to cut it off and give you a bunch of stitches. I'm going to give you options. And I think that in the US, we are procedure oriented and we like to do procedures and we like to give people stitches. And I think it's really important as a caretaker to these patients is to get them the right information and to make sure they aren't getting overtreated, because a lot of skin cancers aren't life-threatening, and particularly in the elderly population who have to get their hip replaced or have an infection or have a lot of complications that can happen from even outpatient procedures. I like to put things in perspective for my patients and say, okay, yes, you have a basal cell. It's going to double in size in the next year, but you know, you also have throat cancer. So let's focus on the thing that matters, you know? So depending on your patient, what your patient can tolerate and what you need to do. For superficial skin cancers, there's really 4 options. You can cut it out with stitches, just a simple excision. You can do electrodessication and curettage, which is where you pretty much just scrape and burn the lesion because the lesion's so superficial on the skin, you don't need to go that deep. You can prescribe a topical cream that they can use, or you can do photodynamic therapy. My complaint with topical creams is that for skin cancers, you have to use them for about 12 weeks, and the cure rate's about 60%, and that's just very hard for anyone to do. I couldn't put a cream on regularly for 12 weeks, and if the cure rate is dependent on somebody doing that accurately, you just want to make sure the person's going to be able to do that treatment at home. Electrodessication and curettage is a fancy word for a very sort of barbaric technique. You numb it up, you burn the area with a hypercator, you then scrape it with a curette, and you do that process 3 times, and that gives you a relatively high cure rate of superficial skin cancers. It leaves people with sort of an ugly nickel-sized white scar in the long run, but when you have patients who have hundreds of skin cancers, you know, you can do it in 3 minutes. It's easy, it's fast, and it's effective. Photodynamic therapy, we talked about a little bit. When you treat it for skin cancer, it's a longer incubation and it's a more powerful light, but it's a really effective treatment. And I have a lot of elderly patients who don't want to undergo surgery, and they're more willing to come in, because the light treatment, you have to come in twice. But they would rather come in twice and not get uncomfortable and not have the stitches and not have the wound care. So it's a very popular treatment. And this is a gentleman who has a skin cancer right by his eye. It's a little superficial basal cell. And, you know, 2 light treatments and it's gone, and there's no scar, and there was very minimal wound care. So it's an easy thing you can do for your patients. It doesn't pay as well as doing Mohs, but it's a much nicer thing to do. So if somebody has an invasive skin cancer, this is where the biopsy matters, because if they have an invasive skin cancer or it's an aggressive type of skin cancer, you really do need to cut it out, and you need to give them, you need to take it out with enough margins to make sure you get all of it, or you need to do something called Mohs micrographic surgery, which we'll go into. It's a type of surgery that has a very high cure rate for skin cancers. In the US, we really don't do that much radiation for skin cancers anymore. It used to be more popular. In Australia, they do a lot of it. The problem with radiation is that it requires 10 to 15 visits, and about 10 to 15 years after the treatment, the area where they receive the treatment has an increased risk of developing skin cancers. So in countries where they do radiation, it's usually in the 75 and older age group, where the likelihood of them having more skin cancers in 10 years is less likely, because their longevity is probably not going to be much longer than the 10 years. Mohs micrographic surgery is a fancy name for a technique of surgery. Mohs was just a gentleman's last name. His name was Frederick Mohs, and he was a medical student in the 1930s. And Mohs micrographic surgery is an indicated technique to use on patients who have skin cancers that meet these criteria, which means it has to be a skin cancer on the head and neck, hands, feet, or genitalia, or in an area where it's just hard to take the recommended margins because it's going to be too tight or too big of a scar. If the lesion's greater than 2 centimeters, if it's a recurrent, meaning it's failed other treatment, if it's an aggressive type of skin cancer, if the patient has had a lot of skin cancer, if the patient is high risk, meaning immunocompromised, like a transplant patient, if the patient is young, and therefore the risk of recurrence is higher because they have a longer lifespan ahead of them, or if it's just a very irregular skin cancer, like a morpheaform skin cancer where you can't see the edges, then you would use Mohs. And what Mohs is instead of, so when we do an excision, you remove a sampling of skin, you send it to the lab breadloafs it, which means that they cut it into about 10 pieces, and they look about 10% of the margin, and they tell you whether or not the skin cancer is clear. When we do Mohs, we actually look at 100% of the margins, and we look at it while the patient is waiting. So you have a much higher cure rate with Mohs because you actually see that all the edges are clear. So what you do is, let's say this is a gentleman who has a skin cancer on his nose. Nose is a cosmetically important place where you don't want to take more than you need to. So you numb them up, and then this is a side view of the skin cancer. So you take out a ring around the skin cancer, and you think you get all of it, but you can see skin cancers grow sort of like tentacles or octopus. They have these little limbs that go out. So even when you think you get all of it, frequently you do have a positive margin. And so then you take that sampling, you divide it, and you look at it under the microscope, and you check all of your margins while the patient waits. And then what you realize is, wait, it's actually still positive in a few areas. Then you go back and you only take skin from the areas which are positive so that the hole doesn't get massively bigger. It just gets smally bigger in the areas where you need to take more tissue. So you continue that. You look at it again under the microscope. And this is that gentleman with the morpheaform basal cell that I did Mohs on. And, he ended up having a big defect. We had to go back a couple times. It went deeper than we thought. And then, you close it all up. And luckily, elderly individuals have lots of wrinkles. And you just hide it in a nice little smile line on them, and they do great. But that's the process. So this is, again, to make sure everyone's awake and paying attention. This is that woman who has had the skin cancer for 30 years. So we debulked it, and then we removed it. And you can see, her eyelid is missing. We're down to the bone, into muscle. We had to remove some of her frontalis muscle. And then we were able, I actually had to go to the operating room with an oculoplastic surgeon to stitch everything back together. And I don't have a picture of how she looks now. She says she looks great, but she won't leave her house to show it to me. But these sometimes can be very, very big procedures. So melanoma. Melanoma are the ones that we worry about the most. Melanoma is, somebody dies every hour from melanoma, and this is why individuals need full body skin exams, and particularly elderly men. When you see them, when you're helping them get dressed, when you're helping them bathe, when you're rolling them in the bed, look at their backs, because that's where elderly men get melanoma. And melanoma is incredibly curable if we find it early. If we find it late, it's deadly. The risk of getting melanoma is about 1 in 55. We're doing a better job of finding it earlier, and people are surviving melanoma, but there is also more melanoma because people are living longer and we're getting more exposure to the sun. The risk for melanoma is a little bit still not well understood. There seems to be two types of melanomas, one that are related to intermittent intense sun exposure. So it's sort of a disease of the wealthy. It's people who go to the Caribbean and burn for a week or two and then go back a couple years later. And that's one group of individuals who get melanoma. And then there's another group where it's really primarily family history. Your dad had it, you've got greater than 100 moles, you have funny looking moles, and you get it, and you get it at 25 or at 35. Melanoma is I think actually the most common cancer in men and women between the ages of 25 and 40. There's lots of types of melanoma. Again, these are not terminology that you need to be familiar with, but it's about knowing that melanoma can present a lot of different ways. You need to be suspicious. And the first one is Lentigo Maligna, which is, again, just a fancy name for a superficial skin cancer or melanoma on the head and neck of the aging adult. So it's just a brown patch. It's a brown patch that's getting bigger, and we don't know why it's getting bigger. And you do a little biopsy on it, and it's a skin cancer. These are all Lentigo malignas of different sizes and shapes. None of them look normal. Those are all things that you'd be concerned about, but sometimes they can be very subtle because as we age, we get a lot of brown spots. And so it's hard to determine what's a normal brown spot versus what's a skin cancer. Very, very dark brown spot in a Hispanic gentleman. Again, more little brown spots. The one behind this woman's ear is, subtle, except for the fact that there's that black area in it. When you get an area that really looks black you want to be suspicious. I'm going to move that so that it's not in the way. Melanoma in situ is also just a superficial melanoma. Lentigo Maligna is primarily on the head and neck. Melanoma in situ can be anywhere on the body. Just a big black ink spot-like area. Sometimes they can be very light in color, which always is scary to me, where they can be a pink-brown scaly area. They can get quite large before a patient brings it to your attention, or you'll notice it on a patient. Superficial spreading melanomas have an invasive component. So melanomas are stage 0 until they start to invade, and once they go from the epidermis into the dermis, then they become a stage 1 melanoma. And the most important factor for determining the survival from a melanoma is its depth. So if we get them when they're superficial, when they're stage 0, stage 1, great. They get a big scar, but that's all they get. They're done. There's no additional workup necessary. If they get so that they're deeper, they're in the stage 2, 3 category, then they have to have sentinel lymph node biopsies, and they have to make extensive workup, and that's when it's much harder to treat the individual. So these have a little bit thicker component than the skin cancers I've shown you this far. You can feel them, and there's going to be some depth to them, and that's concerning. This lesion is scary because it's dark and brown, but it also has that area of regression where the skin is white in the middle of it, and regression is actually a clue for melanoma. So if you have a brown area with a central white area where there maybe used to be pigment and there isn't pigment there anymore, that's a clue that you're worried about it. Again, this is a big black area with a central regression where it used to be darker and is starting to lighten up as a melanoma moves outward. And this is a melanoma on an elderly gentleman's back. Lentigo Maligna and melanoma can become invasive melanoma, and this is an invasive melanoma on the back of a gentleman's ear. Nodular melanoma are the scary ones, and the fact that these are the ones that grow down really quickly. So, the spot may not have been there 3 months ago, and it shows up and it grows really quickly. And not only does it grow down quickly, it spreads to the lymph nodes quickly. So new black spot is growing quickly, that's thickening up. Those are things that we have to be really suspicious of. Acrolentigious melanoma is just a fancy word for melanoma on the hands and feet. Melanoma is much less common in individuals, in pigmented individuals, than it is in lighter-skinned individuals. But if you are a pigmented individual, the skin cancer that you're most at risk for is melanoma of the hands and feet. And so what happens is it's on the bottom of the feet, it's underneath the nails, and frequently these are areas that are not regularly examined, so the lesions can get quite large and be quite deep before the individual gets a diagnosis. And individuals who have pigmented skin often can have normal banding of their nails, where they can have a little area where it's a little bit darker or a little bit lighter. If it's less than 3 millimeters and it doesn't involve your cuticle, it's usually just part of their genetic makeup. But if it's thicker than 3 millimeters, or if this one does, it involves the cuticle of the nail, that's worrisome for a skin cancer. Amelanotic melanoma is the lesion that I worry about the most because it looks like a pink papule. It doesn't look like anything. And because of that, it's ignored, and by the time you diagnose it, it's usually well out of the barn, and the prognosis is poor. And it can just be a pink papule. It looks like a basal cell or a squamous cell or a benign little growth, and it's a melanoma. So melanoma, really, the growth phase and how quickly it's going to kill someone really depends on the type of melanoma it is. A nodular melanoma is going to grow much faster than a superficial spreading melanoma. Even though melanomas are far less common than basal cells or squamous cells, it causes 75% of the deaths from skin cancer. So it's the one, when I do a skin exam, what I'm looking for is melanoma. That's the thing I worry about. The good news is that if we catch it early, the survival is 99% for 5 years. It's just the goal is we have to be educated, we have to be looking for it, and we have to biopsy it quickly and early. Looking at a lesion, and this is what I want to teach you guys, is that there are things that should make you think, oh, this needs to be biopsied. And they're called the ABCDEs of melanoma. And A stands for asymmetry, so the lesion isn't perfectly round. If you drew a line through the middle of it, the left side and the right side wouldn't be symmetric. Same thing, the border is irregular, it's scalloped, or there's regression, or there's some sort of indentation. It has lots of different colors, particularly dark colors. So, we all have moles, and even if somebody has a black mole, if it's uniformly black, that's much less worrisome than a mole that's light and dark and speckled. Things that are bigger than a pencil eraser, or things that are growing, those are also things that you need to look at with greater suspicion. And that's what the evolving stands for, is that it's growing, it's changing, it's new. It's normal to continue to get moles until about 45. After 45, your moles shouldn't grow or change. And if they do, it should be evaluated. So melanoma, the most important thing with melanoma is you have to do a biopsy, and you have to do a good biopsy. You need to get enough of it out that you can know exactly how deep it is, so you know how best to treat it. In the derm literature, what you're encouraged to do is actually do an incisional biopsy. On a busy day, it's very hard to do incisional biopsies on every single pigmented lesion you're worried about. And so the second best thing is to either do a punch biopsy or a deep, wide shave, just to make sure you get deep enough so that you get the depth of the tumor. Because prognosis is based on the depth. So if you do a shave biopsy of a melanoma and you don't get to the bottom of it, you can't accurately give that patient information about what their survival is. And that's, a horrible situation to be in. Any report you get after you do a biopsy or after somebody does a biopsy, it has to have these 5 things in it. And these 5 points determine what the patient's prognosis is. So you want to know the thickness in millimeters. You want to know whether or not it's ulcerated. Ulceration is an increased risk of metastases. The mitotic rate is a new thing that was just added in 2010. The more mitoses they are per millimeter squared, the worse the prognosis. You want to know whether or not your biopsy was clear at the lateral or deep margins, and then the Clark level, which talks about how deep into the skin it's invaded. So is it in the top layer of the skin, the middle layer of the skin, or is it into the fat? This is the most up-to-date staging for melanoma. And as I was saying before, what my job is, and what care providers in general job is we want to find them when they're in situ, meaning they're just in the top layer of the skin, or that they're less than a millimeter in depth. After that, they have to go to the oncologist. That's when you talk about chemotherapy. That's where you do lymph node dissections. That's where I send them to Dr. Bird and, let him do his oncology magic. And this also, the statistic just shows you the 5-year or the 10-year survival. If you have a superficial basal cell, your survival, it could be very good. But also, if you have a superficial basal cell that has mitoses and is ulcerated, your survival is actually only 85%. So even these incredibly superficial basal or melanomas, if they have a number of negative prognostic factors such as mitoses and ulceration, the prognosis isn't anywhere near as good. It used to be recommended that you do imaging for individuals who have melanoma. It's not anymore. If they have stage 1, you don't do imaging. You only recommend sentinel lymph node biopsies if they have negative prognostic factors or if it's a deep tumor. And the treatment of melanoma, without question, is surgical excision. There is some stuff in the literature, I don't know if any of you have heard about it, about imiquimod, which is that same chemical that was FDA approved for the treatment of genital warts, helping with superficial melanomas. And there are case reports of melanoma being cured by imiquimod, but there also are case reports of individuals who were treated with imiquimod and the melanoma progressed and then metastasized. So I don't use imiquimod unless I absolutely have to because the patient's refusing any other treatment option. When we do surgery for melanoma, it really is about taking that extra tissue. It's not about Mohs. Mohs is when we want to save as much skin as possible for the patient. For melanoma, the cure comes with taking a bigger margin. So, if it's an invasive melanoma, I have to take a centimeter all the way around it. And even if it's on their nose or on their cheek, that's what's going to give them the highest cure rate. For people who have melanomas, these are individuals who need to have regular skin exams by a dermatologist every 4 to 6 months. Their risk of having another melanoma is increased after they've had one. And so these are people we really watch like a hawk. Okay, so that's all the big, bad, scary stuff. So now we're just going to end with some of the incredibly common things that we don't need to worry about that you're going to see every day on people's skin. And it's mostly just to reassure you that these are things that you can just tell the patient, hey, it's okay. Seborrheic keratoses can be thought of as barnacles. They're little growths that we get starting about the age of 40, and you just keep getting them. Your risk of getting them is increased if you have a parent who has them, and they're these waxy, sort of crusty little papules that you can get anywhere. Women get them under their breasts, men and women get them on their back. They can be quite dark in color, and they can be quite light. Pretty much we're all going to get them at some point, and some people get hundreds of them and some people get one or two. But this is somebody who has hundreds of them, and you guys have probably seen backs like this, these elderly gentlemen who are just covered with these gray, brown, speckled areas. And why they get concerning is they can get irritated. And you can see this is a woman who was covered with seborrheic keratoses, and she has a number of them that are sort of yellow, crusty red, and that usually makes people a little bit nervous. If they are ignored and that redness goes away, then you have nothing to worry about. Because they stick up, they rub clothes, they rub on your belt, they rub under the bra, and it's very common for them to become a little bit inflamed. And as long as that goes away, you can just reassure the patient. I always just tell them, put moisturizer on it, ignore it, try not to scratch it, and usually it just will, the redness will go away. This is a gentleman who's covered in them as well. And treatment for these, so first of all, treatment is not necessary. I probably get asked 15 times a day to remove seborrheic keratoses. It's not covered by insurance. But people don't like them because they're itchy and they're unattractive. And the easiest way to get rid of them is to lightly freeze them with liquid nitrogen, or you can numb them up and just shave them off or curette them off. Epidermoid cysts, everybody gets these as well. They are sort of firm papules underneath the skin. People get them on their scalp. They're actually inherited in an autosomal dominant fashion, so frequently people who get them, parents had them. People who had a lot of acne in their teenage years get a lot of cysts as they get older. Cyst removals are not covered by Medicare, even though I feel like every old man I see has multiple of them, and he always wants me to remove them. You can always identify a cyst because it has a central dell area, and it usually has sort of an unpleasant odor. And if you squeeze it, sometimes you get this white, sort of smelly, cheesy-like stuff out of it. Again, they don't need to be treated. If they get inflamed and red, it's not because they're infected. It's because the cyst has ruptured and all of that cheesy material is caught underneath the skin, and it leads to your body having a reaction to it. And when that happens, what I do is I just open it up and I drain out all of that cheesy material, and that will settle down the cyst. And then I have them come back and I remove the cyst with the cyst wall. If you don't get out all of the cyst wall, the cyst will regrow. And it's very common for people and lots of different, like in primary care and dermatology, just to do an incision and drainage in it, but leave the cyst wall behind, and then the cyst just regrows a couple years later. Lipomas are also incredibly common, and you just keep getting more of them as you get older. There are some autosomally dominantly inherited things of lipomas. Men frequently get lipomas on the back of their neck and shoulders areas. Women frequently get them on their arms and legs. They're just an overgrowth of fat cells. They're nothing to worry about, and they're very soft and they're very mobile. They're actually softer than cysts, but they can look very similar. And I actually love removing them. You can use like a little incision and then pop them all out through a very small hole, but they don't need to be removed. So I try to just sort of encourage patients to keep them. If they get really big and they're noticeable through their shirt or something, then I will remove them for patients. But similar to the cyst, if you leave any of the lobules of the fat behind, it will regrow. So if you're going to remove it, you want to remove all of it with its encasing. Solar lentigines, it's just a fancy name for age spots or liver spots. Everyone has them. They're related to the sun. There's really no good way of getting rid of them. And why they matter is that it's normal to have sunspots. It's not normal to have melanoma. So when you're looking at skin, what I always try to tell people is you want to look for the ugly duckling. So you're going to have this woman who's just covered in sunspots, and then there's going to be one that's much darker or much larger. That's the one that you're worried about. And this is just normal age spots on the back of somebody's hand, normal sunspots. They can get quite large on the face, and they're just related to the sun and the passage of time. People can get them on the lips, and those can be concerning just because they get to be so dark. And if you aren't sure if the lesion's growing, then you do need to do a biopsy because melanoma on the lip is relatively common as well. There's no good treatment for lentigos. Pretty much I just tell people to wear sunscreen, and that will help make the spots a little bit lighter. In the cosmetic world, yes, there's lesion creams we can use, there's lasers we can use, but they're not worrisome. Nevi is a fancy word for moles. Everybody has them. Some people have more than others. I was taking pictures of my husband's back last night to get more pictures for us. So this is a hairy mole on my husband's back. Hair out of a mole is actually usually a good sign. It usually means that they've had it for a long time and it's nothing to worry about. They can be pebbly and look like seborrheic keratoses. And then some people have dysplastic moles, which are larger, more irregular. So they meet some of the criteria for melanoma, and that's the tricky part. And that's, why I look at skin all day, every day, is that I've gotten, I think, pretty good at figuring out what's a funny looking mole versus what's a melanoma. But I always tell my patients and the doctors I work with, I'd much rather have you send me somebody for a normal mole than for you to ignore a spot that you aren't sure about and have it end up being melanoma. And the worst thing is they get a scar from a biopsy, but you know what? That's better than having melanoma. But these are funny looking moles. One has a little bit of regression in the middle. One's really, really large, and those are tricky. And you just have to watch them and monitor them and biopsy them sometimes. Lots of moles. So the most important thing with moles and with people who have a lot of moles is you just got to watch them. I send patients for total body photography. If I have a patient who has more than 100 moles or a history of atypical moles or melanoma, I send them for total body photography, and then they get a copy of the pictures. I have a copy of the pictures, and then they can check. And they're like, this looks like it's changing. They look at their picture, and they're like, oh, it is changing, and then that's worrisome. That's what's going to make me biopsy it, not a funny-looking mole that has looked funny for 20 years. That's just the way that person makes a mole. When you do a biopsy of a mole, it can come back as one of 5 things: normal, mildly atypical, moderately atypical, severely atypical, or melanoma. And pretty much you need to treat the top 3. You don't need to treat the bottom 2. A moderately atypical or severely atypical is recommended that you do re-excise those. And then clearly melanoma you need to treat. But a mildly atypical mole you don't need to remove. It can just stay there, and because it's not going to turn into anything worrisome. Sebaceous hyperplasia is important to know about just because it can look a lot like a basal cell. It's these little pearly papules, kind of like the way I describe basal cells, on the forehead. But what's different is that usually people have a lot of them. They're usually pretty uniform, and they're common in individuals who've been in the sun a lot and individuals who had a lot of acne. And all it is it's the sweat gland pushing up onto the surface of the skin. And sometimes I can't tell, and when I can't tell, I do a biopsy because you want to make sure it's not a basal cell. People can get them on their cheek, and you can just see the light reflecting from all these little papules on the cheek. Again, just a woman who had a lot of acne as a teenager, and she gets all these little pearly little papules on her forehead that are sebaceous hyperplasia, not basal cells. Again, they don't need to be treated. People come to me because they don't like them, and then there are cosmetic ways of getting rid of them, but they're not worrisome. Cherry angiomas, everybody gets cherry angiomas. This is my husband again. Little red spot, and he's only 35, but I'm sure he'll have hundreds of them. And they're just these little red spots. Women get them when they're pregnant, and you just sort of keep getting them. They can thrombose or turn from red to purple, and that just means that they've got a little scab or a blockage, and so it's not red anymore, it's purple. And then people can get hundreds of them on their chest and back. Not worrisome at all. We remove them if they bleed or if they're causing the person some discomfort. Acrocordae is the fancy word for skin cancer or for skin tags. Skin tags are incredibly common in people who are obese and people who have diabetes. And also there's just a genetic predisposition for them. They don't need to be treated, but they sometimes get caught on things, can tear, and can cause an infection. And they are frequently common on the back of the neck as well. So I frequently do little snip excisions for patients to remove these, but again, they don't need to be removed. Senile purpura is a fancy word for just those little bit of bruising that people get on the backs of their hands. It's very common in elderly individuals who have thin skin from being on prednisone for half their life, individuals who've been in the sun a lot, and the sun has broken down the collagen in their skin and in their blood vessels to the point where it just doesn't have much turgor. So every time they bump their hand against something or put their hand in their pocket, they rub their skin and it causes it to make these little bruises. It's not a very good picture, but I was having trouble finding good pictures of it. But it's very common, and I frequently get asked by patients, what is this? Why do I get it? And it's really not treatable. It's just part of the medicines they've been on. Venous lakes are these little dilated blue papules that you see on elderly individuals, usually ears and lips. And frequently you're worried that it's a melanoma or a pigmented lesion because it's this dark blue purple lesion. And when you have somebody come in with all of them, my little trick is if you have a slide, you want to put like a glass slide up against it, and what you'll be able to do is you'll actually be able to make the lesion disappear by pressure because you push the blood out of it, and then you're like, okay, this isn't a melanoma, it's just a broken blood vessel. They're very common on the lip, usually secondary to sun exposure leading to the dilation of the blood vessel. There's another little one on the lip. Again, don't need to be treated. We can treat them if people want them treated. And so that's it. I just was going to have you guys look at some pictures and say, okay, is this worrisome or is it isn't worrisome? So, if you saw this papule on a patient of yours, would you be worried about it? No, exactly. This is a seborrheic keratosis. It's nice and uniform. It's waxy. It's stuck on. Not anything to worry about. You can say, don't worry about that, sir. This is a crusty papule on the back of the hand. What would you worry about that? Yeah, that's something you should think twice about. You'd ask them, is that tender? If they said it was tender, then you'd say, okay, that's something that we should probably get looked at. If it's not tender, it's probably just a pre-skin cancer, an actinic keratosis, and at some point down the road, somebody can freeze it with some liquid nitrogen for the patient. What about this? This is bad. This is bad. This is something that needs a nice, deep, wide incisional biopsy. We're thinking melanoma, and we want to make sure we get the right depth on it. Non-healing little erosion in the corner of the nose. Yeah, exactly. So it's little, it's not that impressive, but the fact it doesn't heal, it's probably the beginning of a basal cell. And then, not that great of a picture, but it's like some sort of subcutaneous nodule. Not worrisome, probably a cyst or a lipoma. You want to reassure the patient, nothing to worry about. If they really hate it, then send them off to a dermatologist. And then, incredibly commonly, sometimes people have these moles on their abdomen, and it's not a mole. It's actually an accessory nipple. And we have mammillary lines that run from our nipples like down towards our belly button in sort of a V shape. And people can have up to 6 accessory nipples. And I see a lot of pregnant patients. And I would say probably once a week someone comes and is like, I have this mole that's changing, and it's an accessory nipple that's getting darker from the hormones from her pregnancy. So it's just one of those things where sometimes, even at the age of 80, people don't realize they have an accessory nipple. And that's it. So does anybody have any questions for me? So that's a very good question. No. Removing moles, particularly normal moles, does not decrease the likelihood of someone developing melanoma. I think historically people did used to remove moles, and they think somewhere between 60 and 90% of melanomas develop de novo, meaning in normal skin, not in a mole. So even by removing the mole, you don't remove the melanocytes, which are the pigmented skin cells that lead to the development of melanoma. Prevention of skin cancer is primarily done by protecting yourself from the sun and not using tanning beds. And that has been shown very clearly. Tanning bed use increases your risk of developing skin cancer somewhere between 75% and 250%. And that is something that we're really actively trying to educate people on. And then also not being in the sun for the sake of sunbathing, wearing your sunscreen. I tell my patients, be active, enjoy yourself, but wear a hat and don't lay in the sun just for the sake of getting tan. Like if you're going to be outside, be doing a sport and having yourself covered up during the hottest times during the day. And intermittent burns is clearly a risk factor for skin cancer.
Other questions? I'm not getting questions from the site, unfortunately. I think it might be.
We scared them off.
Yeah. Would you mind repeating my email? It's barbc@uw.
Oh, yes. Any questions, please email them to
uw.edu.
uw.edu. Yeah.
We also recommend patients to be on the sun without sunscreen for a little bit because due to
Vitamin D.
Yes. How long is it safe?
So this is a big argument, I think, between the geriatric population and the dermatologists and some of the endocrinologists. The data for the Pacific Northwest is that even if people who are very, very fair, like type 1 and type 2 skin, you will not get as much vitamin D as your body needs, even if you never wore sunscreen in the Pacific Northwest. Then as people have darker skin types, that their need is even higher. So I uniformly recommend to my patients that they take vitamin D supplement, particularly if they don't eat foods that are high in vitamin D. They say, depending on what you read, they say for a fair-skinned individual, 15 minutes of exposure to your face and backs of your hands 3 days a week will give you your necessary vitamin D. I am a skeptic a little bit, but that's a load of bahooey because you can't give somebody that sort of numbers because the strength of the sun and how much vitamin D activation that's going to happen on your skin really depends on what time of day it is, where you are in relation to the equator, and so I think it makes more sense to just make sure they have the controlled supplementation of vitamin D. The other thing is I do think that we've gone to an extreme, and I have a lot of patients who are getting 10,000 units of vitamin D a day, and we don't know what that does, but that's a lot for your liver and kidneys to process. And so I really do believe that, and this is what the internal medicine article that came out recommends, is that you really want to recommend vitamin D, but in a moderation. So they're saying somewhere between 1,000 to 5,000 units a day is sort of the maximum that should be used. I do check vitamin D levels on patients that I'm worried about, and I have them take somewhere between 2,000 units, usually between 1,000 and 2,000 units a day, and I recheck it at 4 to 6 months. But I don't count on the Pacific Northwest sun to get people's vitamin D where it needs to be.
Wyoming is asking, do you recommend the HPV vaccine to prevent squamous cell carcinomas?
So I recommend the HPV vaccine for lots of reasons. I think, unfortunately, it's not readily available for our age group. It's really for the 25 and under group. But the human papillomavirus does cause squamous cells, and if you don't have the human papillomavirus, you're less likely to get squamous cell. So I do think it would be helpful. And there, in the organ transplant group, there is some interest in having organ transplant patients get vaccinated before they're transplanted to protect them from developing squamous cells, or at least to protect them from some types of squamous cells after transplant.
And another question, what to do with the squamous cell on the toenails? Is this slower or something to refer if they are in 80s or 90s?
Unfortunately, squamous cells on the nails can metastasize, and it's something that should be referred. Our goal is always to maintain function, but sometimes you do need to remove the nail and the nail bed to keep it from spreading.
And what about light boxes for light therapy or tanning booths? Do these cause skin problems or cancers?
So yes, exactly. So we used to do a lot of light therapy for psoriasis in dermatology, and we've now gotten better at using specific wavelengths. So instead of doing light boxes that were broad spectrum UVA, UVB boxes, we're now doing something called narrow band UVB, which is just a very thin band of radiation, which seems to be less likely to be associated with skin cancer. But tanning has now been very, very popular for 40 years. We have really good data to show that tanning beds cause skin cancer. I see probably 20 to 30 patients under the age of 40 who have multiple skin cancers, who are all kids who used tanning beds before they went to prom and homecoming. And they're beautiful young women who have skin cancer and don't have a family history from it, but they used a lot of tanning beds before the age of 18.
Other questions?
How do you differentiate a severe case of psoriasis from, because with psoriasis it comes and goes, it comes and goes, it comes and goes. So how do you differentiate
That from a
that
skin cancer?
from a skin cancer, or does it progress?
No. So psoriasis is totally different than skin cancer, which is good. And that's a good question, and that's training and how often you see it. Psoriasis develops in very typical places. It's the backs of the elbows, it's the knees, it's on the hands, and it's it's not usually just a little isolated area on the chest.
It's widespread.
It's more widespread, but also it's okay to treat something and think, okay, let's say this is eczema, let's say this is psoriasis. Try a steroid cream on it for a couple weeks, see if it goes away. If it goes away, great, then it was eczema or psoriasis. If it doesn't go away, or if it gets worse, or if it comes back with a vengeance, then it needs to be biopsied.
Are there any good reference book or online materials for primary care health professional can use before they refer?
Yes. What's wonderful about the internet is that you can get really, really good pictures on the internet. So if you type in skin cancer or squamous cell or something like that, you can get pictures of it, which is always, I think, really helpful because sometimes pictures are worth 1,000 words. There's a great red book called Fitzpatrick that is a wonderful thing for primary care doctors. It's just got lots of pictures and like the most important 3 to 5 points on different diagnoses and the basics of treating it and what you need to be worried about. And it's Fitzpatrick, and it's this red book, and it's a soft-bound book that you can sort of keep on your shelf and bust out when you need it. For Fitzpatrick.
Anything else? Thank you so much.